We're hosting Dr. George Yiachos again from, well, it depends on what we're talking about, but I'm going to go with Florida, Naples, Florida. You guys know him if you've been following the EBU masterminds. He's been with us for quite some time. He's a cardiologist and one of the most respected doctors in our network, I think. He's on our board. And I think some of that just comes from his great personality and also his just insight as a cardiologist. It's there's not very many of those out there in terms of the functional medicine space. So excited to host him today. This has been in the works for about 6 months, and he's been traveling and speaking. Was it just the peptide conference last week you spoke at?
Peptide, and then the hormone conference a couple of months ago. I think it was in March, and a few webinars here and there.
Yeah, and then you've also got your book that you released, correct?
Yeah, heart of the matter. And basically, I wanted to. It's really interesting how it goes. So you write this book, and it's like people realize where you stand on the care, and when it comes to cardiology, the moment they hear something other than a statin, people are very interested. It's pretty. So I tried to make it as comprehensive as I could, and as natural as I could, and I incorporated a lot of the stuff that we do from an ozone and IV infusion perspective too. So that's in the last chapter. It actually gets a little detailed there.
So am
I
I
could even
hearing
tell you how
right?
much what I mix curcumin with in that book, by the way. So anyway,
I'll read your book to find out how you mix
yeah.
curcumin.
Mhm.
Did I hear you correct? And you're getting a little bit of your natural colleagues kind of saying, "Wow, what are you doing these days?" And is it positive?
Yeah, no, it's not just the natural colleagues, even the official cardiologists. It's so funny. So I take my boards, I'm a cardiologist, but when people come to see me here, they're saying, well, my real cardio, I go, what are you talking about? I'm a real cardiologist. I just happen to know a little bit other than writing a prescription for a statin. So it's the natural people like having this as a buffer because it is a little scary when you're dealing with a cardiac condition. And to be bold enough to tell somebody, don't take a statin, do these things. It takes experience for people to be bold enough to do that if they don't have a cardiac background. So I think they're using me as a safety blanket a lot, and hopefully they're learning from me. And that's exactly what I want to tap into here. I said holistic care for this presentation because the reality is what we do here as a group keeps people away from having cardiac issues in the future. And I think we're more important than the cardiologist. And hopefully I can convince you of that by the time we get to the end of the presentation here. So
So you're the real cardiologist.
I don't know if I'm the real cardiologist, but I'm a damn cardiologist. It's so
Yeah,
um,
I assume a lot of you are here to hear that exact conversation on hormones and peptides and other services, wellness, longevity, interventional services that Dr. Yakos uses. He interviewed me on his podcast, me and Christina for Procaine, and he sends me links and he's been on several different podcasts, but his own podcast. The one I just listened to is on therapeutic plasma exchange and just those interviews and how you see it as a cardiologist. So, some of this stuff is relatively new, like hormones and how does it affect the heart. And, um, like I say, I think a lot of us here are encouraged by a true cardiologist giving us, real data on that. Is your book printed and is it accessible?
yeah, it's accessible on Amazon. I'm going to show you guys the link a little bit later, but if you type
Okay.
in my name and Heart of the Matter, it pops up.
And when you do get real time, you're going to send it to me so that I can speak from, I didn't know it was available to purchase otherwise. I would have just done that, but okay, I am in Michigan this week. I'm at this little tiny Airbnb on the lake. I hope that the internet connection and the Zoom connection remain strong. I do have people, my team on here so they can keep the Zoom going in case something were to go glitchy on my end. And thankfully, George is prepared with a few slides to share. And if something happens to me, then I will get back on. But before we get started, I just wanted to remind you of our last for the summer, even though summer seems like it just started. But our last neural therapy and Ibutrain is the second week in July coming up, and I think we've only got one seat left for neural therapy. And George is just, he came, he was just telling me some of his success stories with just Procaine in general. I think just putting it wherever he can put it in nerve disruption and how great that's been for his practice. But we've got that, and then ozone and Ibu training as well. You can stay for 1 day, for 2 days, for 3 days. Happy to host you in Idaho. It's very affordable, but that will be, well, I think what we'll end up doing is just skipping August and going to September, but maybe October, just because summer comes around and a lot of travel, and then September gets busy with school, back to school, and all these other things. So, anyway, take advantage of that if you're wanting to get that done this summer. And then we also had our mastermind from last month that's been posted in our platform. You can find that there. Um, and then I've been trying to post and keep some updates going about every Wednesday and Thursday. So if you're not part of that network, then you can log in at our webpage, ozonetraining.com/community. Just go to the community page. And then George is going to tell you where his book is at later on. But yeah, we better turn the time over to you for those few slides and great, great conversation you're about to share with us.
It's late in the day, so I'm going to try to zoom through them, and you guys could always look at my slides at your own time. So I don't necessarily have to spend a lot of time on my 80 slides. Anyway, so so heart of the matter, ozones, hormones, and the sweet zones. And I'll try to explain what all that stuff is because we started off with a hormone conversation, and then I was getting some feedback that we want to hear about peptides and we want to hear, and of course, I always want to bring it back to how ozone can play a role here. So I practice in Naples, the way Kim was saying. I also practice in New York. I have a podcast called Decoding the Health Matrix, and the book is called Heart of the Matter: The Complete Guide to Preventing and Reversing Cardiovascular Disease. So I've been doing this for a while, and I think I have the experience to be called a true cardiologist. And so we're very good as traditional cardiologists to deal with symptomatic coronary artery disease. And you see where all the life-saving happens. It's inside this cath lab where, some plaque ruptured and you had to open it up with a stent. And cardiologists are awesome at doing that kind of stuff. And I think everybody would admit that in an emergency, being in a hospital for that kind of care is truly important. And time is muscle. But conventional cardiology sucks at prevention, and that's where we kick butt, right? So, and I think we are capable of doing things before they ever get to that point, and secondarily after they get to that point. And we shouldn't be afraid to flex our muscles on that kind of stuff. So, conventional cardiology, I make fun of them because everything is at the heart, and they're so focused on the heart that they actually don't look at the rest of the body. And the reality is that a lot of things are happening in the rest of the body that are impacting the heart, just like the heart impacts the rest of the body. So it's a full circle kind of thing. It's not something where you just look at the heart and you have all the answers. So instead of actually having somebody who watches that way, we've had a medical school system that's been set up, and the standard of care is a 15-minute consult with a doctor who's rather mediocre at what they do. And the big heroes are the ones that have stented your artery open. But after that, they're really mediocre in what they're doing besides throwing some prescription medications at you. And, it gets to, it hurts when I do this, so stop doing that kind of care. And that's mediocrities for you. That's good enough. And whatever gets the bills paid. And Hippocrates was the first published functional medicine doctor, so a fellow Greek. And so he basically said that illnesses do not come upon us out of the blue. They are developed from small daily sins against nature. And when enough sins have accumulated, illnesses will suddenly appear. And it certainly feels like cardiology and coronary artery disease comes out that way, but some people just don't understand that. And so this is my favorite organ. It beats 2 billion times over a lifespan. It pumps 2,000 gallons of blood every day. And the heart disease statistics are rather crazy. And we're talking about 874,000 deaths in 2019. It hasn't budged that much. It's gone down a little bit. And people are still having strokes, which it's the same disease process too. And most people don't even know they have cardiovascular disease until after they have an event. So, they have that clutching of the chest. They start getting leg swelling. They're getting shortness of breath when they're exerting themselves, or just like a third of the people who have a heart attack, they die suddenly, and that's the first clue that they had heart disease because they weren't screened appropriately. And medically accepted risk factors include tobacco use. I think that's a big one and probably one of the biggest modifiable risk factors. Excuse me a second. And type 2 diabetes is right up there. And I put question marks next to the cholesterol because there's much ado about the wrong thing. And I'm going to go into that detail a little bit more. Of course, hypertension, premature coronary artery disease because of a family history. And that even is questionable in my mind. And because there is such a thing as epigenetics, and you can impact even your family history by doing the right stuff. And of course, a prior history of myocardial infarction predisposes you to another myocardial infarction. But here are the relative risk factors: being postmenopausal, advancing age. You can have heart attacks because it's drug induced, right? Taking too much Claritin D or doing cocaine. Or females have a risk of having a spontaneous coronary artery dissection. That's another form of coronary artery disease. And then the ones that most people don't talk about too much are what happens after infections, like viruses, bacteria, vaccines, coagulation disorders. So there's a lot of reasons why these happen. And the reality is it's been admitted that we only know about 10% of the bacterial species that exist in the world. And the chronic stealth infections like chlamydia, Borrelia, Bartonella, even a gut dysbiosis could be responsible for cardiovascular disease, parasites. And so if that's the case, we should be looking for stealth infections too in our evaluations. And of course, there's all sorts of toxic exposures that could lead to coronary disease, heavy metals, EMF is probably playing a bigger role than we know. Lipopolysaccharides from gram-negative infections and COVID infection or even a COVID vaccine has been a major culprit. So it's bound to keep, and I got to tell you, the vaccine is going to keep the medical profession busy for a while. Maybe when they finally admit that it's doing that stuff, we can get somewhere. And of course, stress, metabolic, genetic, and nutritional disorders. So, despite all of the stents, the thrombolytics that people get in the hospital, the statins, the wonderful food pyramid that had everything backwards, and the blood pressure medications, we've actually not had any significant impact on cardiovascular events. We're still having pretty much the same amount of heart attacks every year, but more people are surviving them. If they don't die suddenly, more people are surviving them with more heart muscle because it's known that the faster you get to a plaque and open it up, the more the muscle is going to survive. But still, heart disease is number one, despite all that rapidly advancing technology and stuff that we can do to save people during a heart attack. And, cholesterol has been completely demonized. So, it's the mother of all hormones. You need it for your sex hormones. You need it to make vitamin D. And you need it for good brain function, honestly, and appropriate membrane integrity of the cells. So cholesterol has been demonized. And yeah, of course, we know about the various kinds of cholesterol. The human brain's got it's 60% fat and 25% cholesterol. And it's pretty well known that a low-fat diet and statin drug treatments increase your susceptibility to Alzheimer's. And elevated triglycerides, which actually are not good from a cardiovascular perspective, have actually been shown to be associated with better memory function. It's a little strange. But this might have something to do with the way the mitochondria are behaving in the brain. So the cholesterol paradox is that half of the people who die from a cardiovascular event do not have an elevated cholesterol. So it should be a mystery why those people died if cholesterol is the problem. And less than half the people who die from a heart attack had a high cholesterol. And high HDL levels are supposed to be associated with a low incidence of coronary heart disease, but 50% or more of the people that have their first heart attack don't have a suboptimal HDL. So something else is going on. And one of the things that physicians are starting to pick up on this, I think we in this field are a little bit more attuned to it. But inflammatory cholesterol is where it's at. If you're going to deal with cholesterol, this is what you want to look at. And the modalities that we use in the wellness industry actually works on this. So ApoB, LDL particle number, LP little a, which is mostly genetic and partly environmental. So you can impact your LPA levels if you eat better, but it's never going to go completely down to normal. And the problem with LPA, people think that it causes plaques. That's not the problem. LP little a basically blocks the part of a clot that your body usually attacks to dissolve it. So that's why a high LP little a is sort of dangerous. And if people are having repeated events with high LP little a's, they're even sending people for plasma exchanges. They're pretty much trying to remove as much of that as possible. And every few weeks, these patients are getting plasma exchanges. They tend to have LPAs that are in the 400, 500 range, and they're having repeated events. Those are the ones that are doing that kind of therapy. Here in Naples, there are probably 20 patients out of the whole population here that need to get that kind of a plasma exchange on a consistent basis. Oxidized LDL, very important to look at because that's what causes a plaque. The NMR profile tells you about the LDL particle number, among other things. And this TMAO, I put a question mark next to it because it's not clear if TMAO being high causes disease or if it's associated, but your gut dysbiosis can cause elevated TMAOs. And just remember that when you check your trimethylamine oxide levels on somebody, that if they had a lot of fish in the 48 hours before, they could falsely have elevated TMAO levels. So you got to make sure you modulate their fish intake when you do that blood test. So triglycerides, right under type 2 diabetes, is a very important risk factor. And it's tied to insulin resistance. It causes a lot of inflammation. And it's been very dramatically shown that if you can keep your triglycerides below that 150 range in people who have hypertriglyceridemia, you will make an impact on any existing plaque. You'll actually make it shrink, and you could even make it less inflamed. So dealing with triglycerides is way more important than dealing with a total cholesterol or an LDL if your oxidized LDL and all these other markers that I'm talking about are low. Now, this is a very important slide. This comes from Denmark. And so just so you know, when we treat people's cholesterols because they're high and we don't know anything else about them, we're trying to get that LDL under 100. When people have coronary disease, you try to get it down to 55. And if you have diabetes or other high risk factors, you're supposed to get it down to 35. And here's a really interesting slide that they pulled out of the population in Denmark. And they found that all-cause mortality is at its lowest if your LDL runs about 140. Really interesting. Your all-cause mortality, if you're not getting lipid lowering therapy, again, 140. But if you're getting therapy and you're lowering your cholesterol, when you go below 89, you're actually having more deaths. So the guidelines that we have to try to appease the fact that people continue to have heart attacks and lowering the LDL very low, we're actually probably harming people, definitely women, but we're harming people. We're affecting their longevity. And since it takes a long time to see somebody die from such an event, we're not really making that connection, but it's there, and it's been seen. And it turns out that they do the same thing with LDL, HDL, and total cholesterol. And all-cause mortality is higher when you're above on the LDL. If you're above 200 or if you're below 50, you have higher mortality than if you're at 96. So these arrows that we're pointing to show where the lowest mortality is with your total cholesterol and with your HDL. In the past, we used to think that going under 300 was helpful because you were hyperviscous and had a higher risk for clotting if you were over 300. So, and if you were below 160, you had a higher risk of having a cardiovascular event and dying for some reason. So this cardiovascular mortality that's been looked at, non-cardiovascular mortality and all-cause mortality, lower is not necessarily better, is the whole point. And elderly people at guidelines are 275% more likely to die compared to those with higher cholesterols. Really interesting. Sorry. So there's definitely a connection between a lower cholesterol and a higher likelihood of early death. So I think we already went through this information. Let me go down a little bit more. There we go. So do statins work? And the answer is they do, but they've done studies in people after heart attacks, and they keep mentioning that there's a 12% relative risk reduction, but in reality, the absolute risk reduction is only 0.33%. Not very impactful. You start somebody on a statin, you have to treat about 140 people to prevent one heart attack. At the end of 5 years of being on a statin, you have to treat 30 people to prevent a single heart attack. So there's definitely some benefit to long-term use. It is an anti-inflammatory. It is sort of like an antibiotic, but you need to get past the potential other problems. And one thing that's very well known, aside from the muscle aches and the liver inflammation, is that it brings on higher hemoglobin A1C, more insulin resistance, and potentially even type 2 diabetes in people who are not being careful with other factors. So if you ever see somebody with one of these borderline sugar levels and they're on a statin, and all of a sudden you take them off of it and you put them on other things to lower their cholesterol, all of a sudden their sugars get better. I see that all the time. And the dementia thing is definitely a connection. And then on your patients, if you find people are having side effects with these kinds of medications, you're just trying to help them out. Yes, CoQ10, but GG is very important too. They sort of like work in sequence to try to reverse the side effects that you're getting from the statins. So you should always do CoQ10 and GG together. If you've ever noticed somebody's on CoQ10 and it's still not doing the job, add GG or get them off the damn statin is the best thing to do. So there's all sorts of therapies out there. There's statins, and now there's the injectables, the PCSK9 inhibitors. There's these RNA injections that you take once, maybe twice a year. There's Nexletol, bempedoic acid, which basically lowers LDL receptors. And then there's ezetimibe, which I think is the safest out of all the things if you're trying to reduce these inflammatory numbers. And then there's phenofibrates, which they're wonderful at lowering triglycerides. But I remember when I was first doing pharmacology over 30 years ago that there was a connection with dying from some reason that they could not identify. Motor vehicle accidents apparently were up. Impacting the cholesterol with statins, you'll impact the quality of the plaque. You'll make it harder. So if you ever have somebody who gets a calcium score, that's how you put them on a statin and it goes higher. You cause that, right? So when people have a high calcium score, remember that. And there's minimal impact on cardiovascular events year to year, but there may be some impact if you could be on it for more than 5 years is what happens. And as long as you're not getting any of those side effects, that's something that people have to consider. So cardiovascular disease is still the number one cause of death in the United States. And I think that's emblematic of treating the symptom and not the root cause, which is what we're really good at. So insulin resistance, big problem. You have insulin resistance, you have diabetes, you have mildly elevated sugars. You're always going to have more problems with coronary disease, congestive heart failure, strokes, and other kinds of deaths. And obesity plays a big role in this. So with that centripetal fat, with that visceral fat, you're getting more pre-diabetics, you're getting more diabetics, you're having higher blood pressures, and you have a higher risk for developing fatty buildups. And I'm getting to something here. I'm not just going to cover all of this stuff, but I think you need this as a background. And then these next few slides basically show you that in men and in women, having hyperimpaired fasting glucose and type 2 diabetes puts you at a higher cardiovascular risk. So I don't think we really need to focus on these too much, but that's just a simple truth. And what's really interesting is that this metabolic syndrome has certain diagnostic criteria, like what's your waist circumference, what's your body mass index, what's your sugar, what's your hemoglobin A1C, but nobody checks the fasting insulin level, which precedes a lot of these problems way before the hemoglobin A1C ever becomes abnormal. And they don't include body composition analysis. They assume that the BMI is good enough, but knowing if somebody has visceral fat and centripetal fat makes a big difference in what kind of care you're going to be offering these people. So for the people that do in-body composition analysis out there, you have a very powerful tool to reduce risks. So make sure you're getting those in-body compositions on people. That's that special scale that you stand on, you hold the handles, and it gives you all this information. And there's a lot of people suffering with prediabetes, hyperinsulinemia, insulin resistance, and they're being missed because nobody thinks it's important enough to diagnose. But it really helps if you can get a 3-year lead on people that are at risk for developing diabetes and these other conditions that are so tightly tied to coronary disease. And abdominal obesity is definitely a big deal. So, that's what's putting you at risk for a variety of things. Um, And the critical link is that with this hyperinsulin state, these hyperglycemic states, these advanced glycation end products that are being produced, that you're essentially causing low-grade chronic inflammation. And that's why when somebody finally gets diagnosed with type 2 diabetes, you're going to find out they already have coronary disease because it's been going on way before that sugar crossed that line. So if you're not checking insulin levels at an early stage, and if you're not keeping those fasting insulin levels below 5, you got somebody that has risk, and you have to, of course, tie that to other findings in the whole workup. And here's the big question. So why does this happen as you get older? Because if you look, people start to get overweight. They start to get even bigger as they get older. And I think you guys know what I'm driving at here. There's an age-related decline of a variety of things, right? So you tend to get reduced mitochondrial biogenesis. You start to have more mitochondrial DNA mutations as time goes on. Start to have impaired mitophagy. You have decreased oxidative phosphorylation, and you have diminished antioxidant defenses. And the reality is there's a reason why that's happening, and this is the big reason. It's age-related hormone decline. So all of these things that we just described rely on having normal levels of estrogen, testosterone, growth hormone, thyroid hormones around. When they're impaired, all those other systems get involved, and you start accelerating the risks associated with these disease states. And what's very important is that as these reactive oxygen species are going up, as you're getting exposed to other toxins from your diet, as you're becoming insulin resistant, you're starting to activate this NLRP3 inflammasome, which has been tied to cardiovascular disease, dementia, it's been tied to cancer, and it's basically a protein complex that exists in your cells that when activated, starts a whole cascade of events that leads to even more inflammation. And it's been shown, they recently came up with this update, and they found that hormone replacement therapy is geroprotective, right? It protects you from being old. That's what that means. And essentially, it addresses all of the 12 hallmarks of aging. And with HRT, within 10 years of menopause, very clearly, you're reducing cardiovascular risk up to 50%. Alzheimer's disease can go down 35%, bone fractures 50 to 60%. And I'm going to argue that even past the 10-year mark, there is use for hormones. And some of my youngest looking 90-year-old patients have been on hormones since they went through menopause. So and they don't look 90. I have to be honest with you. They look like they're 60. It's pretty amazing. So, these hallmarks of aging, genomic instability, telomere attrition, epigenetic alterations, loss of the ability to appropriately process proteins. These are all triggers for inflammasome activity, by the way. Disabled macroautophagy, the deregulated nutrient sensing, mitochondrial dysfunction, that's a big one for us, cellular senescence, stem cell exhaustion. All of this stuff happens more when there aren't appropriate hormone levels around. So, and it's a bidirectional relationship. In other words, that it turns out your mitochondria work better when your hormones are in the normal range. So that's very important to know. So if you feel that you're putting somebody through, let's say, ozone therapy or peptides to boost their mitochondrial function, you're putting them through HBOT or you're putting them through red light therapy, if their hormones are not doing well, and that's probably going to reflect in the fact that they're not really getting the response that you expected. So if ever a therapy that you're doing doesn't seem impactful, think about this because the body is not prepped to do its job appropriately, is what's going on. It's going through inflammation. And when these hormones drop, you get fat redistribution, your mitochondria are getting more challenged, you're getting more oxidative stress, cytokine dysregulation, and all these things just feed into the problems that we tend to see as we get older. So that's why there's an increased risk with age for heart attacks. That's why there's an increased risk with age for cancers. So it's not just because you're older, it's because your chemical environment has changed dramatically as you were getting older. So from age 30 on, males start to have a decline in the testosterone levels. Now, a lot of males don't drop to the point where they're deficient, so you don't have to worry about those people too much, but there is an impact on their body habitus. And in females, very clearly, there's an advantage to hormones, right? So they start to go through perimenopause, and what tends to happen, I think on this next slide, is you're going to see as you go through menopause, you start to drop your testosterone levels. This is in women. You start to drop your estradiol levels, and you start to drop your progesterone levels. And most of the time, it's going to be growth hormone, testosterone, and progesterone that's going to be dropping first. And that's why a lot of times you're going to start getting from your patients, I'm getting more anxious, I'm not sleeping well, I'm getting brain fog, I'm getting irritable because there's relative estrogen dominance with that progesterone drop that's happened. And the testosterone is playing some role in your body habits, right? You start to gain body fat, you start to lose muscle mass. And growth hormone also has an impact on your body fat and muscle mass through its impact on insulin-like growth factor. So, if you've ever talked to people who take peptides, they like to take this CGC and hypermorelin, samorelin, tesamorelin. What they're trying to do is get all of the benefits from growth hormone, but when it comes to the body type, it's what it does to insulin-like growth factor that gives that advantage of losing body fat centrally and increasing your muscle mass. And then, of course, there's people that actually replace human growth hormone directly, and that's always a tactic as well. Anyway, so as you're going through these hormonal changes, that's what's leading to these increased risk for atherogenic plaque, prediabetes, high blood pressure, hyperuricemia, chronic inflammation. So your all the pauses, the thyroid pauses, the menopauses, the andropauses, all of these adrenal pauses, they all lead to various things that we do not find desirable when we look in the mirror, but it's even less desirable in terms of the way it's impacting your health. So, with all of these pauses, you're just amplifying systemic inflammation. So, if you happen to have heavy metal disease, or if you happen to have a gut problem and your hormones are off, you're worse off than if your hormones were in a normal state because your recuperative mechanisms are just not working as well when those levels are not where they need to be. So, so this is why age matters when it comes to these things. And importantly, from a heart perspective, that's why there's an increased risk for atherosclerotic heart disease, increased risk for heart attacks, and even developing a cardiomyopathy. So this is the famous image that has been ingrained in a lot of people, not necessarily, in just the cardiology realm, but somewhere in your 20s, you develop a foam cell, and this foam cell graduates to bringing in more LDL particles. The plaque starts to grow, and eventually it ruptures, and that's what causes the heart attack because the clot that forms there blocks off the artery, blood's not getting through. And the mechanism here is that plaque is going around, it's rubbing on the sides, it's depositing. This has been the image that's been given to us. And so cholesterol has long been thought to be the culprit, but there's a lot of other things. There's layers of blood vessels that run along the surface of the coronary artery, and these things are called the vasa vasorum, and they're running along the adventitia. And in the adventitia, which is far away from the inner part of the coronary artery, this is a very reactive layer. This is where inflammation gets triggered. And when inflammation gets triggered, I don't know, from a heavy metal, from an infection, from whatever, these vasa vasorum, which we're picturing here, start to multiply, start to get more densely populated in the adventitia. And what ends up happening is the blood vessels start to get soft, engorged, spongy. They're becoming leaky. And there's a reason why that happens, but this whole outside in process of causing inflammation is just as important as something happening on the inside of the blood vessel. And that's probably why you can't always explain the coronary artery problem just by looking at what's happening inside of the blood vessel. So here, you could see bacteria rubbing on here. It's like a lot of fun with AI when you play around with these things. Anyway, so you tend to get a lot of local cytokine accumulations. There's increased wall tension. You have a lot of oxidized lipids that form. There's a lot of extravasated blood products, and all these things signal for fibrin to come to your endothelial space. Fibrin then asks for platelets to come, and then platelets start to bring growth factors and healing factors. But if you have a lot of oxidized lipids around, this is the opportunity for them to get into your blood vessel. And heavy metals can cause that kind of toxicity to the blood vessel on the outside and on the inside. And of course, gram-negative bacteria and the LPSs that they form. So, the kind of stuff that you find in gums and teeth. And that's why I always focus on asking a question about your dental health and your gum health. And essentially, this is sort of what's more of a trigger. It's not just some random thing that happened at age 20 that led to this. And I've seen people develop significant coronary disease within the course of 3 months because I've happened to have done some sort of an imaging on them at time zero, then something happened and we image again, and it's a completely different picture. And level of inflammation really is an issue. And it could be one of those things that we usually screen for that's causing the problem. And I think it absolutely is. Um, so inflammation is the key. And we know that coronary artery disease is related to inflammation, but it's mitochondrial dysfunction that's not letting you get back, right? Because if you're dealing with all of these insults that could be leading to inflammation all over your body and your mitochondria becoming overwhelmed, you can start to not recover from things. Inflammation can sort of magnify, and this is where you get that increased risk for cardiovascular disease. So here's another piece of the puzzle here, and this is called the glycocheck test. I'm sure you guys have seen it around, maybe at the conferences. So this is actually an image of red blood cells racing through a capillary. So I want you to imagine the vasa vasorum, which tend to be very small vessels. Your red blood cells are running through there. And what's really interesting is you see that there's a clear area. These red blood cells are electrically being pushed away from the wall. And that's what you want to see. You want them not going to the wall. And if you look here and you can actually do this in the office. I do this in the office all the time. But you want to see spacing between the red blood cells when they're traveling through the capillaries. And we can image this with a little tongue test. And when you don't have that spacing there, that means there's something missing. And this is the glycocalyx, right? So I saw this and I'm going, of course, that's why people can actually get coronary disease under certain circumstances and not others. And this mucousy kind of layer called the glycocalyx, and this is the sweet zone that I was referring to on the opening slide. It's basically glycosaminoglycans, and it's got heparan sulfate in there. It's a blood thinner, so this way you don't actually, you're producing your own at this layer. You're producing nitric oxide with glycocalyx. It's not just the endothelium that does that. And when this is around and nice and thick, you've built the wall, you've built the border that's keeping the invaders out. And the United States needs to learn a lesson from this. So the next thing is that we have the glycocalyx. This is what it looks like. I think that's amazing. And I don't know if you're looking at this, but it looks like a gut to me, right? So you're looking at that protective barrier. And I'm telling you that when this protective barrier goes away, some really interesting things happen. So this is a site of endothelial injury. Something happened here where the glycocalyx has actually gone down, and there is a propensity for something to happen here. This will happen when your insulin levels are high, when you have an infection. They were able to do studies on people with COVID, and they were in the hospital. They were in the intensive care unit, and the patients that had a thicker glycocalyx survived and went home, and the ones that didn't have a glycocalyx died. Really interesting and not something that's well known. However, the university hospitals now all over the United States are now getting these machines and running tests because they realize that this is a big key, and it's definitely going to be a new point that people are going to try to come up with some sort of monoclonal antibody. So the pharmaceutical industry is going to try to take advantage of this knowledge is what's happening. So in this picture, what's happening is you're seeing this blue zone. That's the glycocalyx. And over here is them in a controlled circumstance injecting oxidized LDL. And you see that it's staying away from this layer, which is the endothelium, which is where the plaque likes to build up. In this next frame, what you're seeing is the glycocalyx has been degraded. And all of a sudden, the oxidized LDL is getting past the glycocalyx and starting to invade the endothelium. So this is a big deal. So your glycocalyx is just as important, probably more so than your cholesterol, because you want to reduce your oxidized LDL, but you also want to increase the protective barrier that's there. And there are ways to do that very simply. So in this image, what you're seeing is a glycocalyx that's been degraded. You see there's no space between the blood cells going by at all. And then what they do is they sort of flush it so that you can't see the red blood cells. And you see these little white marks going by, and you see that they're sticking to the wall. Those are white blood cells that are not just flowing through now, they're sticking to the wall because they're going to be creating more of the inflammatory cascade essentially. So with that glycocalyx going down, you're opening up the opportunities for inflammation to happen at the level of the endothelium. And if you have enough oxidized products around, you're going to start developing a plaque in that area. Now, this is a really interesting image. And so this is on the left-hand side, you're looking at the glycocalyx that's healthy. You're seeing the layer right below it, that's the endothelium. And these are the other layers. And remember, this is at the capillary level, and the capillaries are responsible for 99% of the blood flow in your body. Not just these vessels here that go across the top of your heart, called the coronaries, are such a small proportion, and they actually are not responsible for getting the blood into the muscle. They're responsible for getting the blood to this area so that you can feed your organ. And this is somebody whose glycocalyx has been completely eradicated. Look what's happening here. This is all edema. This is all inflammation. And imagine this is going to any organ, right? And when it goes to any organ, you're compromising the blood, the oxygen, the removal of toxins, and you're creating a circumstance where that organ is not going to function normally. So the glycocalyx is a barrier to protect you from those kinds of things. And this is just basically a cartoon showing that. Like we said, it's glycosaminoglycans, proteoglycans, hyaluronic acid, heparan sulfate. That's what's in this barrier. So it's a vascular barrier. It regulates permeability. It senses shear stress. It prevents white blood cells and platelets from adhering to the area. So this way, you could actually not allow clots to form, and things are non-sticky. And I don't know how many of you, what is her name? Senef, Dr. Senef, who basically has talked about how things like taurine and sulfur-based compounds are very important because they actually create an electrostatic charge that keeps the red blood cells from sticking. They create a Teflon kind of surface. And that's because they support glycocalyx. She didn't know that when Stephanie Seneff, when she came up with all of that, she's just like an engineer from MIT. She's not even a physician, doctor in health, but she put this all together and she's so amazing. But it turns out these sulfur-based things like glutathione, taurine, what they do is they're actually helping you support your glycocalyx structure. And that's why taurine is actually a really important thing in people that have coronary artery disease. That should be something that you think about from an IV perspective and even from an oral perspective. So the damaging here basically leads to a lot of the things you see happening in the heart and in other organs. And it does create a vicious cycle. It promotes more inflammation and reactive oxygen species, and it worsens endothelial function if you don't have it grow back. And there are other things we do that can help bring this back. So the key triggers: inflammation, cytokines, oxidative stress, reactive oxygen species, hyperglycemia, diabetes, actually having a shock episode like the COVID patients that were in shock because of that huge cytokine storm that they were going through. And if they had enough of a shock to their system, the glycocalyx disappears and they die. Disturbed or abnormal shear stress. So anywhere where there's a bend in the vessel, if the blood's not flowing in a laminar manner, you can actually degrade the glycocalyx there, and that can act as a focus where fatty buildups can form. Having high volumes, like in people with congestive heart failure, having oxidized LDL. Ooh, what a surprise. Age-related hormone decline. What a surprise, right? These things degrade your glycocalyx. And other clinical conditions: trauma, sepsis, chronic kidney disease, viral infections, and surgical procedures. All these stressors impact the way your glycocalyx is behaving. So this is the thing. This is how I look at things in my mind. So some of you might think I'm a little insane, I guess, if I think of things this way. But these are all the toxicities and the deficiencies on the left. And the more you get exposed to this, the more you move up this ramp to where you can get immune and endothelial dysfunction. And they do this because they actually activate the NLRP3 inflammasome. And this inflammation, if the mitochondria are healthy, they can actually take this oxidative stress and get you down to the bottom of the ramp. But if the mitochondria are not healthy, that's when you tend to progress to these immune and endothelial dysfunctions areas where you have a higher risk for cancer, heart disease, strokes, and chronic autoimmune disease. And in here, I'm trying to figure out where I'm going to put the glycocalyx because it's a barrier. So anything that I can do to, I don't know if it happens here or here, but supporting the glycocalyx is another piece of the puzzle here. Because even if you're inflamed, if you actually have a good glycocalyx and you're supporting it, you can actually minimize how much damage you're going to expose your body to. So, so this is the NLRP3 inflammasome, and it can get activated by bacterial components, viral components, fungal components, parasites. And essentially, if you're not, if you have external damage from molecules that are attacking your cells, or if you're misfolding proteins because you're getting older and you don't have enough hormones around, these are all things that are going to trigger this NLRP3 inflammasome, which sets up this whole cascade for inflammation and a vicious cycle of inflammation that leads to coronary disease and other disease. And essentially, you cause what they call pyroptosis. So it's inflammatory apoptosis. So we always talk about how you want things to die in a healthy manner. Well, when you activate the NLRP3, they don't die in a healthy manner. They actually cause progressive inflammation. And so there are things out there that block the NLRP3 inflammasome. And I was talking about this with Kim a little bit earlier. But they have actual, and the reason why these compounds came about is because they were a point of attack for rheumatologic patients who had rheumatoid arthritis or all sorts of collagen vascular problems. And they would use these things to try to suppress inflammation as a way to sort of spare the need for steroids long term. But disulfiram antabuse, I don't know if you guys remember this, but you would give this to alcoholics. So this way, if they drank any alcohol, they would get sick to their stomach, and you would try to negatively reinforce the behavior. But it turns out it's actually a very powerful NLRP3 inflammasome. But if you give it to somebody that likes to have a glass of wine, they're not going to like you. And then colchicine is a very common one that we use. So it's a partial inhibitor of NLRP3 inflammasome, and that's why it became useful. It's useful actually for all sorts of chronic inflammatory conditions, very inflamed coronary arteries, COVID. If you have a COVID infection and you're trying to mitigate how it's going to impact your body, colchicine was a really big tool that we were using. We also use it for pericarditis, and it's very powerful at what it does. And of course, they use it for gout. So on the natural side, this is where you guys can capitalize on this knowledge, literally and figuratively. So you have access to curcumin, you have access to resveratrol, quercetin, EGCG, omega-3 fatty acids, astaxanthins. All these things are very powerful suppressors of the NLRP3 inflammasome. So when people are inflamed, whatever the reason, not just coronary, I use curcumin and I use EGCG as part of my IV infusion protocols. I give them omega-3 fatty acids primarily in the krill oil format, so this way they can get a lot of astaxanthins as well. I use resveratrol. These things you have access in your IV labs. Don't be afraid to use them because they do impact inflammation. So, of course, Big Pharma knows this and they're off to the races. They're trying to come up with a monoclonal antibody, the RNA therapy that suppresses the NLRP3 inflammasome. When I was taking a class at Harvard, the professor was so proud that they were talking about this. And then I went to him and I go, you know that curcumin blocks the NLRP3 inflammasome? He goes, it does? I go, you know, you can give it IV and it does. So all he was focused on was the fact that he got money to do a study on a monoclonal antibody that blocks the NLRP3 inflammasome. He thought it was so novel, but we've been doing it all along for years. So, conventional cardiology, when it comes to cardiovascular disease, they're going to talk about lose weight, eat less fat, less salt, low cholesterol, lower your cholesterol, lower your sugar. They're going to put you on medications like aspirin, blood thinners, statins, BP meds, stents, bypass, monoclonal. But what do we do in integrative cardiology? And what we should be doing in the wellness industry is you remove the toxicities. I think everybody knows that part. You have to correct the deficiencies. And hormones are a big deal about that. Fixing your glycocalyx is very important. And optimizing if you have mitochondrial dysfunction, you got to fix that. And that's where ozone is a wonderful thing. You want to mitigate your NLRP3 inflammasome. You want to boost your barrier function, as we said. And you want to, by doing these things, you will actually reduce the need for prescription medications, especially if you make an impact on their body composition, and you're actually giving them, getting their body's environment back to where they were at age 35, 40. They will be functioning like an amazing race car. And for those of you who do hormone therapy, you see it. It's a game changer. Um, and so essentially, the mitochondria are a very important piece of the puzzle here. And as you can tell, this is a complex picture I'm sort of painting, but they're all interrelated, right? So that mitochondria needs to operate optimally while you're reducing the burden that it needs to fight. And that's the key. And that's where EBU is fantastic. That's where MAH is fantastic. That's where ozonated glycerin is fantastic too. So they can do their HBOT. I still love my ozone. They can do red light therapy, but I still love my ozone. So ozone's very powerful. Use it, and because there is definitely a need for it in everybody who is in a later age group. So, and that's because the mitochondria, they basically they keep the reactive oxygen species under control when they're operating appropriately. It gives you efficient energy production and it supports anti-inflammatory states. And then obviously you want to do things that also improve mitophagy and mitochondrial biogenesis. So it turns out these are all the things that are mitochondrial boosters, and that's zone two aerobic exercise, high intensity interval training, resistance and strength training, which I think is not um, stressed enough. I think that has to be a very important piece of the puzzle, whether they're on weight loss medications or not. Resistance training is very important. So, antioxidant-rich diets, Mediterranean-style diet, intermittent fasting, quality sleep, stress management, heat exposure, cold exposure, and of course, ozone therapy. But because somebody said something about peptides, I put these in here too, and that's SS31, MOTS-C. These are very powerful, easy to use peptides that will optimize mitochondrial biogenesis. It will basically help with mitochondrial senescence. Also, it help clear things out, and it boosts your mitochondrial function in general. So these are things to look at. And of course, you have the growth hormone related peptides, which basically will impact body composition. And there's IGF-1 actual peptides. So in other words, they actually have a peptide that is insulin-like growth factor, where if, let's say you want to be a little bit more focused and just deal with the centripetal fat and the visceral fat, you can just give IGF-1 if their IGF-1 levels are too low or on the lower end of where you would want them to be. And I find that a lot of the people that work out hard and they're looking to optimize, if I give them an IGF-1 on the days that they work out, they actually feel that they're getting much bigger results with the same exercise routine. So they feel like they make even more gains than just normalizing their hormones. So hormones, IGF-1 is pretty good. CGC and ipamorelin is very good. MOTS-C, SS31. And then, of course, the FOXO4 dry, that's basically helping you with clearing out senescent cells. There's a whole bunch. Every month they're coming out with more and more of the research ones. So the difference with peptides is which ones are research protocols, and you're explaining to the patient that these are research only, these are not FDA approved, but you're going to find everybody's sort of looking into these things. And then And of course, we skipped targeted nutrients, CoQ10, alpha lipoic acid, B vitamins, magnesium, L-carnitine, PQQ, and urolithin A. And sometimes you have to give the urolithin A specifically because even if you throw as many pomegranates as you can at somebody's gut, they may not be able to make as much urolithin A. So actually giving urolithin A can actually help with the mitochondrial biogenesis. So I think that's an excellent peptide to think about. So when you do this glycocheck testing, these are the compounds that have been shown to actually grow your glycocalyx. So I did my glycocheck score for the first time, and I was embarrassed to say that it came somewhere in the mid-range, and I thought I was taking good care of myself. And I went on something called Revasca. It's this stuff over here, Revasca, and it's got all of these compounds. It's got fucoidan, it's got polysaccharides from aloe. It's got they're always like upgrading which seaweeds are going to be doing the best job. It's got hyaluronic acid, it's got polyphenols, L-citrulline, and it's got superoxide dismutase. And my score over the course of 2 weeks went from the mid-range to above what's considered optimal. It actually went double what's considered optimal. So that was pretty amazing. It turns out there are pharmaceuticals that are available in Europe that can strongly rebuild your glycocalyx, but it's not available here. That's sulodexide. And believe it or not, Jardiance, which we don't think about too much because we think more for weight loss. But when it comes to a cardiovascular issue, these SGLT2 inhibitors, which are now being used for long haul COVID, by the way, with some pretty interesting results. These SGLT2 inhibitors like Jardiance or Farxiga, they actually play a big role in rebuilding your glycocalyx. Peptides, SS31, MOTS-c, GHK copper is one of the most powerful things, and it's the only peptide that directly grows your glycocalyx. The SS31 and the MOTS-c works on the reactive oxygen species part of things. And then, of course, from a supplement perspective, NAC and urolithin A. So, like we said, taurine, glutathione, any of the sulfa-containing compounds will actually boost your glycocalyx. So these are the things that are very simple and you can make a difference. So I didn't bring the slides here because I already had 80 slides, but it turns out you can actually because usually when people have renal disease, there's sort of a progressive decline that's rather predictable. And most nephrologists can actually calculate when they're going to go get to the point where they need dialysis. You put them on glycocheck, they've done these studies, their GFR starts to improve. And then what they did is they stopped it again, they saw it degrade again, and then they started again and it came back up again. So there's a lot to be said about an organ that's mostly, the nephron involves very small blood vessels like capillaries. And if you can get them to work better, you could even improve renal dysfunction. It's been shown that when people have coronary artery disease, the people with the better glycocheck score actually have no chest pain because their capillaries are still getting blood out to the organ system very easily. And the ones that have a lower glycocheck score, they're having angina, right? So I guess from an ozone perspective, mitochondria, because I equate ozone as mitochondrial health, honestly. And everything is modifiable. If you can take away the stressors of the mitochondrial system and you can make them operate better, you're going to be ahead of the game. And so bioidentical hormone replacement therapy, I've used it to improve people's glucose scores, improve their lipid panel, um, uh, and basically reduce symptoms. So they improve your lipid panel, they improve your atherogenic markers, meaning inflammatory markers go down. They have been tied to reduced cardiovascular events, especially estradiol and testosterone. They basically enhance vasomotor function, and that's estrogen primarily. They increase your nitric oxide levels, and they do that themselves, but they also have a positive impact on that glycocalyx. They actually boost. Turns out testosterone and progesterone specifically will actually help grow your glycocalyx. So that's how it has an impact. Um, Testosterone, I think most people know, has a huge anti-inflammatory impact. Progesterone does too. And uh, it's really the improvement in the body composition that you want to shoot for. So if you have people on these weight loss programs and you want to get them off once they hit their goal, if you haven't improved their hormonal status, these are going to be the people that bounce back onto these weight loss medications. And although they do have a benefit from a cardiovascular perspective, to me, fewer medications is better. And I don't consider hormones a medication. I consider them a normalization of your environment. So, and what they do is they basically reduce visceral fat, they reduce centripetal fat, they improve your muscle mass. So metabolically, you're becoming much more powerful when you're using these hormones. You can actually drop your sugar levels, drop your insulin levels at rest, and most importantly, just an improved sense of well-being. And there's nothing better than somebody who works out and they're not in pain for 3 days. There's nothing better than somebody having boosted libido, really enjoying their sex life again. And it just encourages even more improvement in their protocols. So if you've ever met somebody who first goes on hormones, they start to notice a difference and they start exercising more, they start eating better, and they feel more motivated to do these things because they're not stuck at being in pain and not seeing results. They start to see results. And I think that's an important psychological aspect too. Um, and most importantly, I've been able to get people off of statins. I've been able to get them off of blood pressure medications. Um, Blood thinners, it depends a lot. It depends on what's going on in their coronary anatomy. I do love nattokinase, and it does seem that there might be some plaque regression that happens with nattokinase because if you're removing the lattice work of where fatty buildups like to form, then that fatty buildup doesn't have an opportunity to stick there as well. So it's actually more dissolvable. So nattokinase has the ability to prevent clots and to also reduce plaque formation. So and there were plenty of studies that have shown this. The Kronos study for estrogen basically reduced the prevalence of coronary artery calcification. When it came to testosterone therapy, it improved physical function and reduced cardiovascular risk factors. And combined estrogen and testosterone basically improved lipid panels, inflammatory markers, all that kind of stuff. So, and I think they're very safe. Remember, the dangers with hormone replacement therapy had been with artificial progesterone causing cancers, and artificial estrogen, believe it or not, can still give you all the positive impact, but if you take it in an oral route, there's an increased risk for thromboembolic issues. And those are some basic things to remember when it comes to the typical sex hormones. So what I want to do here is I want to impress upon you that you guys could be super Hippocrates, and that what we're doing here is we're improving health span, not just lifespan, and we're trying to be more than just mediocre. And patients are looking for this. Don't be afraid to talk about the heart if you're not a cardiologist. Somebody's got to talk to them about this stuff, and the stuff you do can actually make their life a lot better, and you shouldn't be embarrassed to do that. So this is my podcast, Decoding the Health Matrix with Dr. Gio, and this is the book, and you can find that on Amazon. And that's the end of my 80 slides. I made it, and there are the slides that show how each of the hormones impact mitochondrial function, and that could be in the slide pack if you guys want to look at it. Whew.
Yeah, take a breath. I wish I
Yes.
could speak something halfway intelligent compared to you right now. I wrote down so many notes, and as you came full circle, I think you answered every single one of them, and I was so excited to kind of sound smart. I listened to your other webinar or podcast, whatever it was you sent me, on TPE, therapeutic plasma exchange, where I learned more about the glycocalyx. And so I was like, I didn't know what all your slides were, right? So I was like, oh, I'm going to bring this up and I'm going to have him talk about it. And then you spent so much time, which is great. Um, there's I guess that's one of my questions for anybody listening who's thinking about therapeutic plasma exchange and your information there. Do you have any insight as to what that therapy will do for the glycocalyx?
Well, I think, one of our biggest problems is plastics. And that's probably going to be the most powerful way to clear plastics out of your system is with the therapeutic plasma exchange. You will drop all of your inflammatory cholesterol numbers when you're doing TPE. You will remove all of those toxins on the ramp that we're talking about that are exogenous. You'll get them out of your system. So I think there is some significant power if you're willing to sit down and do a therapeutic plasma exchange. It's probably strongly worth it. I've recently seen, let me see if I have it here. So I recently saw, you know how we were talking about advanced glycation end products? There's actually an assay now that you could actually do a finger prick and they could sort of tell you what your biologic age is according to what your AGEs are. It's a it's a test that's out of somewhere in the Balkans in Europe. They sent me a kit so I could test myself, but I thought that was interesting. I was going to try that out and see what happens. But you know, it's very hard to measure advanced glycation end products, but you know that they're there when the insulin's running high. If you're hyperglycemic or that hemoglobin A1C is borderline, that's the stuff that's happening. You're sort of crystallizing these sugar particles in your all over your body, and your body's reacting to it in an immune manner, and inflammation is getting triggered. So, you know, that hyperglycemic state, that insulin resistance, that's a real killer for us in the United States, and we need to be very focused on that.
In one of your last slides, I was writing notes, and so I missed looking at the slide, but you said XYZ actually reaches the glycocalyx really well. Was it nitric oxide?
Well, nitric oxide can be produced by the glycocalyx and the endothelium.
Okay.
So you're saying are you saying that it reinforces the glycocalyx was the what the question?
Well,
Something that reinforces
you
it?
were going down your list of maybe things that would be helpful, and you're like, this one's really important because it reaches. This is my question going through the and listening to you is what's the best way to reach the glycocalyx in terms of services, in terms of supplements, is because it seems so hard to
Well,
reach.
they pack. You know, you've heard of. I'm sure you've heard of arteriosyl HP, which was like one of the oldest formulations that they had for the glycocalyx. But these seaweed compounds in Ravasca have been shown to be much more powerful. And Dr. Vink, who developed the glycocheck machine, he's actually tested glycocheck scores using arterosyl, endocalyx, and Ravasca. And these seaweed compounds in Ravasca have been really powerful at really jumping the scores.
Okay, so
Um,
spell that. Rivaska.
It's Revasca, and you can go to revasca.com if you guys want to try it out. But it's good stuff. And what's more important is it actually does cause a measurable difference. And we know that making a measurable difference is impactful because they've seen that when they improve glycocheck scores, organ function improves tremendously. They found that if you're an obese person and your glycocheck score is high, you're less likely to have cardiovascular complications and disease states. Whereas if you're obese and you have a low glycocheck score, you're going to be somebody that goes down the usual path of somebody who's running high in weight and high in body fat. So there's all sorts of, like if you go to revasca.com, you could read up on how important that glycocheck is if you guys want to go into that in more detail.
Yeah, I've never heard of that one. That's why I was like, tell me the spelling. So you said test, don't guess, and yet I'm thinking the percentage of most of us walking around with some level of glycocalyx damage is probably high. So I'm thinking I'm gonna get Ravasca as just a daily supplement, and
Yeah,
I'll
but if
find.
your score is over 10, you know what they do with what they do with the score is they break it up into four measurements and then they create something called the microvascular health score. So what they do is they see how many different size capillaries you're recruiting, and this is all from a probe camera that they put under your tongue, that we put under your tongue. Should have brought the machine here. Anyway, so you put it under the tongue, you actually see the capillaries, you actually see the red blood cells going through. It's pretty amazing, actually. And you can see all the various different size of capillaries, and the software in the machine actually collects information about what's a 4 millimeter, 5 millimeter, 6 millimeter capillary. It measures how much blood is traveling through for any period of time. And then it measures the PBR, which is that border between the vessel and the red blood cells. And the bigger that border is, the bigger your glycocalyx is. It's almost like you're looking at a negative. And then they put it together and they create this microvascular health score. And what I do is I look at the breakdowns also. So if I see your capillary recruitment's down, then I know that you need to be doing a little bit more exercise. You might benefit a little bit more with Revasca, but if your your microvascular health score is high, you don't necessarily need to get the supplement. is the whole point. So measuring helps you decide whether you want to throw another supplement on the 50 that you take every morning for breakfast. So
Seriously, how did you know?
yeah, I think all of us here do that kind of stuff
Oh,
sometimes.
it's like yeah. And then I see the money at the end of the year when I spend on supplements. Okay.
Yeah,
So you're talking to medical providers, and I know half of them sitting here are thinking, I need to get this test. It's software. Is it something scalable? Is it
it's a
something that
computer. They sell you the computer with the software on there, with the probe. Do you want me to go run and get it, or are you guys going to look it up and you'll see it online? All right.
spell
And
it again?
so essentially,
Glyco
it's
check.
proprietary. Glycocheck. If you look up Revasca.com, it'll probably take you there too. It might be easier to do it that way.
Okay.
All right. And
Yeah.
so it's they sell the machine to you. The whole kit comes to you. It's like a $26,000 machine. So
Okay.
I currently have interns in my office, so we're going to be running a project, and we're running in-body composition, glycocheck, VO2 max, resting metabolic rate, and their blood work. And I'm having them go on a fishing expedition. They're very excited. So we'll see what kind of conclusions we could draw from all that stuff.
Okay, on the IV side, I think of chelation, I think of plaque X. You and I were talking about curcumin to begin with. You mentioned glutathione. I didn't know about, at least I don't know of a great resource for the green tea IV. But backing up, plaque X, yes or no?
Yeah, absolutely, absolutely. Uh, Listen, phosphatidylcholine is going to help with any kind of a lining issue, and it turns out if you do a search, you're going to find that Plaquex actually boosts your glycocalyx. It's
Okay.
another one of the compounds that could boost your glycocalyx. So
Okay.
and that's probably why it might have a benefit when you're doing those 40 therapies on somebody. It's impacting the glycocalyx and it's impacting the plaque at the same time.
So when we were talking about curcumin, I asked you if you were doing it with phosphatidylcholine, and you were like, yeah, mostly
No,
just
only for my cardiac patients.
but in
Cardiac patients, but
cardiac,
I don't do it. I don't do like if I have a guy that comes in and he's like aware and he injures himself and he's in pain, I only give him curcumin. I usually don't give them Plaquex also,
okay. Okay, now I understand that better.
and it works pretty yeah. But it is part of my cardiac protocol.
Okay. Chelation, TAC 2, TAC 1, TAC 2 studies, are you very familiar? How do you feel about that?
Well, tact one was well, tact two, they're still breaking down the information. I suspect that in the end, when they finally do another study out of Mount Sinai, they're going to find that it's probably definitely beneficial to lower toxic levels of things. And it's probably beneficial because of the nitric oxide boosting that you're getting from chelation, calcium EDTA specifically. I think it's probably worthwhile. Problem always going to be compliance, right? Adherence to a regimen that takes a
40
while
weeks
to
long.
do, so.
Um, However, do you think there's a comparison in terms of outcome to using chelation to remove heavy metals and those burdens to the endothelial, the glycocalyx, as opposed to therapeutic plasma exchange?
Well, therapeutic plasma exchange removes metals, probably more impactfully
That's what
than
I'm asking.
chelation. Yeah.
Okay, that's what I'm asking. Because you even mentioned it might be the nitric oxide is better of a res or I don't know, a trigger, I guess, of
Mhm.
what chelation's doing. Okay, you and I talked yesterday, but I don't want to put any words in your mouth. What are you seeing? What do you think about the use of stem cells, biologics, etc., for this component of glycocalyx and endothelial inflammation?
I think it's excessive for that,
Okay.
right? Everything always works better if you can give a trusted stem cell source, right? Things will repair, things will get better. I don't think you really need that because you have like wonderful natural compounds that build up your glycocalyx. So you don't have to pay $5,000 for a therapy when you could pay a few bucks for a supplement that's going to build up your glycocalyx. Where stem cells really are important, I think, is when you have scarring of the heart, when you have cardiomyopathy, when you have those kinds of conditions where you need to repair and get back to the normal state. That's where stem cells are going to play a big role. And in the past, people used to go to the Dominican Republic and they would actually go through some dangerous things. They would actually inject stem cells into their myocardium. And I had a lot of patients back in New York that would return from those trips and they would have endocarditis and all that stuff. So IV is much better. Obviously, IV therapies that don't cause any kind of significant reactions would be great, and that's where these Muse cells might be playing a bigger role in the stem cell industry as time goes on. There aren't many suppliers of it now, but clearly the talk is that it can actually cause the potential for cancers, because that's always a concern with stem cells, that if you're giving it in a situation where something neoplastic is going on, could you possibly promote that growth? And I think the stem cell industry in general tries to avoid having to give stem cells in those circumstances. Whereas now they're starting to find this subsection of these things called Muse cells, which are very hyper specialized healers. They are mesenchymal stem cells also. And there are companies now that are basically trying to phase out everything except the Muse cell and give those injections. And what's great about it is, the fear that someone's going to go into ARDS because they infuse the stem cells too quick is much lower and almost non-existent, is what seems to be happening. So you could very safely now put it in a 100 cc bag of normal saline, and you're infusing some stem cells very slowly, and you do it at the tail end of your EBU, and you got a Dubai protocol going there. You got people paying, thousands and thousands of dollars to do that in Dubai when you could just do it in your office. I think that's exciting.
Yeah, and the reason why you and I were talking about it, or one of the reasons, is because we do have, well, you had asked me, I hooked you up with a person who I know, a company who I know who is working on this Muse Cell product. And so, because I know half of you are going to email me, text me, and ask me if we can hook you up with that. Yes, I'll be curious to talk with George again in, I don't know, 3, 6 months and see what he is seeing with it. However, I really trust the people that I've worked with so far. So, yes, if you're interested in learning more about a Muse cell product, maybe not for the glycocalyx, but for other things, then hit me up in a message, a text, whatever. I had the
I'll
question,
tell you go ahead.
I was going to change subjects. So, if you have something to say about Muse cells,
Just one last thing. So I've been in contact with that group that you told me about, and they found two distributors for Muse cells, and they're trying to create a relationship right now. So right now, and I know who one of the contacts is. It's somebody that's been all over Instagram, and Kim Kardashian made him famous. So it's one of those situations, and they happen to be here in Florida. So I spoke to that group already. Any case, all right, go ahead. Let's go to the next topic.
I wrote down when you were talking way back about stickiness again at the glycocalyx, or actually just maybe more how plaque, etc. I wrote down nanokinase, ladokinase, and you eventually mentioned it. Do you use that a whole lot in your protocols?
Nattokinase?
Yeah.
Yeah, all the time, all
It
the
doesn't
time.
matter if it's nat I say natokinase, whatever, natokinase, or there's two others, ladokinase. Do you find
Lumbrokinase also, right? Comes from earthworms,
Mhm.
and uh, and then even serapeptase, which is not really the same thing, but a good anti-inflammatory. But nattokinase, A, I use it as part of the COVID protocols. B, if I have somebody that has an elevated LP little a but doesn't want to go on aspirin, I'm going to put them on nattokinase.
Okay.
Again, because of that whole issue about clotting. And usually I'm going to give them anywhere between 4,000 and 6,000 FUs, and that's not a curse. They're fibrinolytic units. And so that's like somewhere between 200 and 300 milligrams of nattokinase.
Okay.
So I do use it quite a bit.
Okay. Long COVID. I mean, I think we all know that the spike protein issue is probably, and well, even just the original virus, and who knows what we want to think about the vaccine and so forth. But damaged or at least inflamed the endothelial tissue. And at this point, I'm guessing probably really is a source of trauma for the glycocalyx. Um,
No, I would say it was a damage to the glycocalyx and eventually the endothelium.
okay.
Yeah. So it's actually even before the endothelium, the glycocalyx has to get destroyed. And that's what they saw during the pandemic.
Patients that died.
Yeah. Not
Um,
one patient. They did a series of patients and they saw that. They
yeah,
could
it's
predict who was
fascinating.
going to make it out of the unit. Yeah.
Um, okay, so I was going to ask, when you get patients coming in for long haul COVID, this is now a description, right? This is now a case. This is now a lot of patients. Are you measuring spike protein in terms of your protocol and seeing any of that change?
So I was, we'll talk about what you said earlier later. Anyway, so yes, if I have any vaccine history, which I ask of everybody, it's how are your eyes? How are your teeth? How's your gut? Did you get the vaccine? That's always there. And if they've gotten the vaccine, I ask for their lot numbers. I usually look them up on how bad is my batch, trying to see if there's any kind of um, sort of a pattern to the people that got that lot number. And a lot of time, you'd be surprised. There's actually a small handful that nothing ever happened. So they obviously got placebo, is what happened. But the other ones are like crazy, crazy kinds of events have happened. You'll see a lot more deaths, a lot more hospitalizations. And then what I'll do is I'm either going to send them to LabCorp where they give you a full quantitative spike analysis, or I'm going to send them to Quest where they do a semi-quantitative, meaning if it's they'll tell you only if it's over 2,500. LabCorp will tell you if it's 10,000.
Yes,
And then, of course, the other inflammatory markers get checked when I'm doing this, and I go about depending on how sick they look. When they come back with those numbers, that's what we come up with, whatever protocol we need to come up with.
perfect. What we were talking about earlier for the rest of you is the EBU filter and doing no the EBU process, the EBU filter, there's some speakers out there on the platform that are talking about provocation for spike protein and then certain elements of the filter and which filter and so forth. I didn't tell you this earlier though, George, is that it is the same practitioner, Dr. Ben Kozubevsky, who has recorded lots of data on seeing the spike protein come down with a particular filter and a particular protocol. So you're going to meet him, pick his brain on it. He's, in my opinion, one of the furthermost experts on EBU and EBU filters. I hope someday I can get him on here. But he has done a lot of testing on it and has seen spike protein come down. Um, I have two at this point now, as much as it was as high as 20,000 and some people coming down to zero. So,
So, are you using that filter that he uses?
yes, I
You are.
switched.
And do we have access to that filter?
Yes, we do.
Okay.
Uh, This is actually the FDA approved Nipro Silentia filter. And so, yes, you have access to FDA approved, obviously, for dialysis, but still a process of testing, safety, efficacy, adverse events, and so forth. But the way it's made and the flow dynamics that it exhibits just doing the procedure, watching the procedure, you can just tell it works so much better in terms of just, the flow. But it is with that filter that we see the best results as well as the lowest occurrence of adverse events. So,
So
yes.
Abraham has a great question. Where do we buy it?
Um, I'm working with anyway, safetubing.com.
Gotcha. And so I have some of the EBU equipment that I purchased. Do you need to make modifications to the EBU machine for this filter to work with it, or can it work with the current setup?
It will work with the current setup. If you have the O3UV EBU full spectrum, you purchased after the name change, and you have the EBU Quantum with QGen, if you have any of the devices, you can use this filter. Any of the devices, because the filter itself is separate, right? Now, each company usually, and again, not outside Best Tubing, Safe Tubing, Malaysian Tubing, whatever, but they usually include their filter of choice when you purchase that tubing. And so the companies, have made their choices, whether it's CTA, whether it's a PES, and there's different types of each one of those. So safe tubing comes with this, I think, great filter, but it's also got a slightly different setup in terms of their tubing. The upgrade you have to make to the machine is to get an upgraded adjustable pump so that that tubing fits in that comes with the filter that we think has the highest safety profile and actually has been shown to be connected to the spike protein decrease.
So it's not a simple change of the filter and put the same pipes on. You actually have to change the pipes too.
They just kind of come as they come together. So you could stay with the same pipes, but then you'd have to purchase separately this other filter, or you could just go to this other company and purchase that filter with their tubing, which is slightly different. But this upgrade, it's at Safe Tubing. It's like a conversion kit. It's like $120 for this. I said filter, I meant pump. And you take off the old one, you put on the new one, and your machine still works. And then you get that other
So
filter.
can you use it with the old tubing? If you put
Yes.
the new, you
It'll,
can.
yep, the red and the blue, they'll plug right into that new filter.
Is
That the
there any way we could have best tubing know what we're talking about when we're calling them?
No, Best Tubing doesn't know, but I've been talking to them. I think they're going to make they're just working on large quantities of inventory is always hard. Um,
Hmm.
but Safe Tubing, if that's what you meant, Safe Tubing does know exactly. You log in and they've got that conversion kit and it comes with the right.
Oh, safe tubing. Okay, sorry.
Yeah, they're really close.
Yeah.
Tubing's the one that most of you are purchasing from. Safe Tubing is the new one where I have been getting my new filter. Now the tubing's a little bit different. And so once you know Ebu, you can really adapt to just about anything out there. But the tubing with Safe Tubing is a little bit different. You have to even cut in your cuvette for now. So I actually have some information on that inside the platform. So if you go in there on the left-hand side, there is eBoo Quantum and eBoo Pro. That's a different device, but that tubing that comes with that device, you can use it with your device too. You just have to change out that adjustable pump.
Okay.
But I would love to hear your feedback. The only thing is that you have to buy 25 sets. They don't come in 10, so it's a little bit more of an initial investment. About the same price. But I would love to have everybody, well, not everybody, but I would love to get feedback on testing compared to, and just even your usership of it. So Robin Rose and Brendan Cochran, who have been out, Robin Rose has been talking about this provocation for the spike protein. Um, she uses it's the same filter by a different name, and that means it's not the FDA approved. But when she talks about my machine gets this outcome, it's the filter that's getting that outcome. Because the machines are all the same, right? Ozone generator attached to UV if you want UV, and a peristaltic pump that's drawing and returning your blood. It's the filter where the magic is, and that is where she also has collected lots of data there.
Gotcha.
Okay, a question in the chat. Where all do you inject procaine, neural therapy in your patients in your practice? Dr. Farah Sultan.
You're asking me?
Yep.
Oh,
I
you
think
are. I inject it everywhere. So, so it depends on the circumstances, but I do the pelvic plexus injections with it. Today, I actually used procaine along with ozonated glycerin for somebody who's got post-herpetic neuralgia that radiates down to the buttock to the point where they can't even sit. And the last time we did it, she had the biggest response she's had yet to any of the things that we've done for her. I've done stellate ganglion injections. I've done celiac injections. A lot of surround the dragons. I can't think of anything else right now. But
Are you
I
doing
use
Surround the Dragon and those like superficial ones with the ozonated glycerin as well?
it depends on where it is. But yes, I have no fear of doing that because it gets great results.
Yeah.
Yeah.
I was telling you I had to put it in my back. We did about 10 patients that day, and I got that like foggy brain for like 10 days. It wasn't like pain. wasn't a headache, but man, it just didn't feel good. And you were talking about what was it? The ratio?
I think we were talking about the percent ozonated glycerin that was injected. So usually you want anywhere from 5 to 10%, and so that's usually what. So I'm going by Dr. Bridge, I believe is his name, right? Yeah, Dr. Bridge. So uh, I guess, I don't know if people are very familiar with using ozonated glycerin, but it's really kicked up quite a bit over the past year. And the data, the knowledge that's growing right now because of all the practitioners that are using it, it's gonna be a big deal, I think, for your care in the future.
I've been using it and love it too.
Yeah.
I had two more, one comment. I don't know if you saw it, so I got to tell you. There's a comment in here about this is the best lecture I've heard in a long time.
Wow, thank you.
Allison, thanks for sharing that. That always makes us feel good. One of the questions I had is on GG. I can't say the word. I can't read my writing. I looked it up though. It's a plant
Gerano
complex.
Geranil.
Yes.
Yeah.
What
Yeah.
is
So
it?
well, CoQ10 and GG are right next to each other. So a lot of times when it gets degraded because of statins and all that kind of stuff, it's not just CoQ10, it's also the GG part that's getting degraded. So that's why sometimes you get only a partial response to CoQ10 because they're also degraded on their GG. So if they're going to be staying on the medication and they're looking for advice, adding GG to the CoQ10 is going to be worthwhile. And I think probably it would be great if you just told your doctor friends about it. They probably don't know anything about that because they're the ones that are going to keep them on statins after all. So
Yeah, I
yeah.
like that. And
Mhm.
where are you getting the green tea IV stuff?
Vertices.
Did you already answer that for me, or was
Yeah.
it
No, no, you asked me about the curcumin. I get the curcumin from
both of them?
Vertices and I get the EGCG from Vertices also. They also have resveratrol, which
Mhm.
is another one that you guys were talking about. I've gotten
Okay.
comfortable with them, even though I know you like your Texas Star place.
I like
Uh,
vertices.
Oh, do you? Okay. So,
Yeah.
I don't know. I've gotten so comfortable with them. I haven't really ordered from Texas Star yet. I'll get there eventually.
I do really like vertices. They had a lull when the 797 compliance came out, and so it was hard to use them. And then
Mhm.
they've bounced back, and so they're great now. And
Yeah.
they're in some of the same states and some different states too. So vertices. Um, all right, I got people asking for slides. I don't recall you saying that you were gonna like send out slides or share slides, but this is being
I could share
recorded.
them. If you guys want to be bored to death reading them on your own, go ahead. So,
Even some
just
comments.
just do me a favor. Don't publish them.
Yes,
Just
that's
study them.
yeah, that's where I get kind of nervous too, is just,
Mhm.
it's proprietary information in so many ways.
Mhm.
So, well, I agree. This is one of the best lectures I've heard in a long time. I always appreciate
Thank
you.
you.
It's always
Thank you.
intelligent, but also relatable. It's so good to have you on the team for all of us,
I'm
cardiologist.
happy to be on the team, honestly. You guys are a great team, and I completely agree with what you've been doing. And again, there are doctors out there that are just, they're hard-headed. This is the way I was trained. By the time they hit about 55, they start to gain some wisdom. So go after those 55-year-old plus cardiologists, and you're going to be able to change their mind.
Somebody's asking me how to spell that GG word, and I'm like, I looked it up.
Geranil geraniol. You're missing an A after the R.
Dang it. Copy and
It's G.
paste.
If you look up GG Anato, they sell a bottle on Designs for Health, GG Anato.
They
So
do
that's
want Designs for Health. Okay, I got an
yeah, yeah.
account
That's right. Whoever spelled that, that's right.
there. You're a linguist as well.
Yes.
Okay, again, so appreciate you. It's late for us
Thank
over
you.
here on the East Coast. I know it took some energy, some time away from your kids, and it was well appreciated. We will send out this recording. We'll post it in our platform. Encourage you to share it. Oh, last thing, are you taking patients? Will you allow people to refer to you in your practices?
Of course. Of
And
course.
the name of your practice?
Oh, it's WPR Medical. So if you go to WPRmedical.com, you could people could see what I do, and you could actually even book an appointment straight from that online resource. So, and you'll actually find there are buttons there that will help you access the media and the stuff that I've done in the past. I try to keep it exciting. I do more than just cardiology, but cardiology is my love. It's true.
Last question. Are you able to, interested, and maybe you want to think about this, allow for some shadowing practitioners to come in and shadow and maybe even learn a little bit about the glycocheck?
Why not?
Okay.
Why not? As long as they're willing to come to Florida, it's fine.
Who's not willing to come to Florida? Okay. Thank you, Dr. Yakos. Again, such a pleasure. Appreciate your time.
Thank you. Thank you.